So thank you for clicking on us. This is the Precision Medicine, a Congressional Snapshot session. And I'm Chad Ramsey, Vice President of Policy here at OCRA. And we're really glad that you took the time to check in on this session. We have some exciting things to share with you. And for most of the work here, I'm going to hand it over to my colleague, Vanessa Kramer, the policy director for OCRA, put together this terrific slide deck for you, and she's going to go through it with you now. So without further ado, I'd like to introduce the inimitable Vanessa Kramer.
Thanks, Chad. Thank you for that introduction. And just want to echo Chad in saying thank you for joining us. We are only going to be able to scratch at the surface of this behemoth topic, but I look forward to diving in to what should be a pretty kind of robust overview. So we're going to kick things off with some level setting. So what is precision medicine? The term is bandied about. It's become a bit of a buzzword in medicine. What does it mean in advocacy and what we do? And for the purposes of this session here, narrowing our scope, what is precision medicine when it comes to ovarian cancer, looking at barriers at the patient level and honing in on cost and coverage and education and awareness as two of the biggest. And then look at what's being done. That is, of course, the raison d'etre of this session. That is what is being done around this topic, this intersection of ovarian cancer and precision medicine at the state level in state legislatures across the country, and then mainly at Congress. And we're going to look at two bills in particular. So a lot to get through here. All right, so precision medicine, what is this term? And first of all, just I think to compare it to traditional medicine, to define traditional medicine is helpful. And I found this graphic, and I think it's a nice anchoring point for this discussion. So traditionally, radiation, chemotherapy, and surgery were the only means by which doctors could treat cancer. With precision medicine, doctors use a patient's genes to uncover clues for treating the disease. And really, it's so much more than genes, right? It's about the particular biomarkers one has, mutations that you're born with, right? And that you develop over the course of your lifetime. So these would be germline mutations versus somatic mutations. The more we learn about cancer and its different sort of molecular signatures, and then also the human genome, it's been an explosion when it comes to the drug development pipeline, because it opens up this whole universe of specific sort of targeted treatments that speak not only to your makeup, but also to your cancer's makeup. So over here, we have what the traditional paradigm looks like. Radiation, you have high energy particles that damage or destroy cancer cells. Chemotherapy attacks the cancer. So this is kind of the course of things. Surgery, operate on part of the body to diagnose or treat the cancer. So as we've seen cancer kind of evolve in this precision medicine space, we've seen it go from, what was once kind of episodic or, oftentimes worst case scenario fatal, to now a chronic condition. Cancer can be kind of treated into chronic long-term care. So it's changed everything. Then over here on this side, you have genetics, gene sequencing, locating cancer-causing genes, hopefully at the earliest stages, immunotherapies, identify ways to customize treatment, find ways to turn immune system on, personalized treatment with immune activating drugs, and then targeted therapy. This one here has special significance to us in the ovarian cancer space because of PARP inhibitors, and those are not right? Chemotherapies, like in this sense over here in the traditional sense, they are more anti-cancer therapies. So they're that personalized treatment tier that arrest the growth of cancer cells, and people are on them for often long periods of time. Okay, so the takeaway from this image and to frame the coming conversation is there is a shifting paradigm afoot. Applications, uses for diagnostic tools born out of precision medicine have grown significantly across the board in oncology. So taking what we just saw in that image and sort of extrapolating it into practice, what does this mean for the patient? So this means, and for us in particular, right? So this means for cancer patients and OC in particular, that it's not just about preventing cancer anymore. Like these diagnostic tools used to be about preventing and controlling risk. Now these gene signatures, all of the tests, the diagnostics that have been born out of precision medicine can also be used to manage treatment and also for cascade testing. So that would be testing for risk in other family members. All right, so this is precision medicine, all good and well. So why on earth would anyone dare to push back on this? It seems like it has a lot of promise. Well, there has been some coverage. STAT did a small series on kind of the pushback earlier this year, and these quotes are taken from that. So, and they get at the main criticism, which is basically all hype, right? That all of this is really expensive. It's been overpromised to patients. And there's questions as to whether or not it actually delivers what it's on all the hype and what has been promised. So the findings of the Human Genome Project were predicted to transform medical care by the year 2010, evoke behavioral change in genetically at-risk individuals, generate new drugs, and improve the effectiveness of old drugs by matching them to patients' genes. Thoughts later captured in the precision medicine mantra, the right drug for the right patient at the right time. Another prediction was that gene therapy would be used to cure both rare and common diseases. Although some niche applications have been found for precision medicine, and gene therapy is now becoming a reality for a few rare diseases, the effects on health are minuscule, while the costs are astronomical. So effects being, right, the good effects, right? There's been a lot of coverage around people who have been sort of given false hopes and feel they've been led on and are now paying really, really costly bills as a result. So that gets at where there is criticism and why that would be. So what draws us apart in the ovarian cancer space is in the past 20 years, and actually much earlier really, with BRCA1 and BRCA2 mutations, those have profoundly changed our understanding of hereditary breast and ovarian cancer, but also of cancer generally speaking. So these were really the first. We are pioneers in this space. And with that, we have amassed a lot of evidence that supports this type of testing and extols or demonstrates its value in clinical treatment. So that second bullet there, guidelines by NCCN, that is, of course, National Comprehensive Cancer Care Network, SGO, and ACOG all agree that anyone with a personal history of ovarian cancer should receive genetic counseling and testing, regardless of any other factor. So ovarian cancer was the first, again, to have guidelines issued calling for this type of testing. And then under the Affordable Care Act, which was fully implemented in 2014, the ACA, through its prevention health benefit, expanded private insurance coverage for genetic counseling and testing for BRCA1, BRCA2 mutations for individuals with family histories indicating HBOC risk. This was around the same time as what was dubbed the Angelina Jolie effect, which was a lot of people, in short, a lot of people possibly, maybe unnecessarily, getting preventative surgeries because Angelina Jolie brought this up, and in the mainstream consciousness, people started seeking out this treatment, and maybe some payers think that they ended up getting these surgeries unnecessarily. Just bringing it up because it's a hook to bring people in. That, of course, there's a lot of different thoughts there, and we aren't taking a position on any which one side per se. But again, so much as using it as a hook for this conversation. All right, so in spite of all of the interest that ovarian cancer in particular, the interest in the action, I should say, has seen when it comes to genetic testing with BRCA1, BRCA2 in sort of the public sphere, what's it like on the ground in patient communities across the country? And the truth is, right, because we were one of the first, we have the most evidence. Insurance coverage for specific individuals has been in place. These coverage benefits vis-a-vis the Affordable Care Act have been in place for some time now. So what does this mean? Okay, guidelines have been in place for over a decade, and yet research alarmingly shows that rates of genetic testing among among ovarian cancer survivors is really bad. So in 2019, JCO published a baseline setting study looking at genetic testing among rates among HBOC providers. They used data from SEER cancer registries in California and Georgia from approximately 83,000 women, and the study found that in 2013 and 2014, roughly 1/3 of women with ovarian cancer underwent genetic testing for inherited BRCA1, BRCA2 mutations as called for under professional guidelines. So this is pretty bad, and it shows that we have a lot of work to do in the advocacy community, right? Like, why are 2/3 of survivors not receiving this type of testing? So that second sub-bullet there before we move on. Among patients who did receive genetic testing, 15% of ovarian cancer patients had actionable gene variants, meaning variants that might warrant changes in treatment, screening, and risk reduction surgeries.
That was 7 years ago too, and so the indications have really exploded and vastly improved for different therapies. And so you can imagine that 15% number in 2013 and 2014 would be much larger in 2021.
That's right. That's right. Thank you, Chad, for hopping in and saying that, which is even all the more frightening and alarming. So this next slide here regarding these findings, the lead researcher said, genetic testing has become quite cheap and accessible, and the study includes a time period, echoing Chad's point, when it was becoming much cheaper. So it's striking that we see such low rates of testing even then, right? So the author suggests that there might be things beyond cost. And one thing we found, just to kind of jump the shark here, is that there are really two things, right? So it's cost, which is ultimately coverage, right? What type of insurance coverage people have? Is it providing testing for everything? And then looking at the cost itself. So cost, coverage, and then also, and this is what Dr. Kurian gets at here, it's also a matter of education and awareness. Do folks need to know that they should be having this type of testing? Like, what are sort of the public awareness campaigns that we have? There aren't really any, which is part of the issue, but where are the failures when it comes to patient education? So the second bullet.
Provider education as well, of course.
And provider, yep, definitely. The second bullet there, the study also revealed racial and socioeconomic disparities in testing rates among women diagnosed with ovarian cancer. So genetic testing rates were far lower for Black women than for white women, and were also lower for uninsured patients than for insured patients. So this kind of follows in thinking about the cost coverage issue as an access barrier. So Dr. Kurian's last bullet there, these findings have uncovered a disparities gap that is much more substantial than I would have thought. So, I will say, we're reading a lot about disparities and health equities, and these issues are finally getting some attention inside the Beltway, on the Hill. Not that they haven't been, hotly debated in the past, but it feels like now we're getting some more resources and maybe some more meaningful debate. But the point of the story is that even given that a lot of numbers, I feel like I've almost been desensitized by how glaring some disparities are in the public health space. But I will say, this is pretty bad, to think that only a third of ovarian cancer survivors have received testing, and that's only for BRCA1 and BRCA2 mutations too. All right, so zooming out, right? So that speaks, we've spoken to the testing for germline. This is the inherited genetic mutations, but often as important in ovarian cancer patients is testing for somatic. So be these acquired mutations that are present in the cancer itself. So these tests are used for tumor profiling or tumor sequencing and depend on an underlying technology called NGS. So to juxtapose, right, NGS is next generation sequencing. Juxtapose that to traditional Sanger sequencing. NGS is really the sizzle and the steak. It is what enables you to, with one sample, one tissue sample, test for a broad, seemingly really endless number of different genetic mutations. So it has changed the game, these tests. And their primary application is for somatic testing. Again, that's the acquired mutations. All right, so to put a bow on it, in the diagnostic testing space, we say that ovarian cancer, and of course we are not a medical provider guideline issuing organization, but we look to the guidelines, and the guidelines say, right, that if ovarian cancer patients require somatic mutation testing, which most providers will tell you if that's the case without issue, without question, I should say, then the ovarian cancer patient deserves and is entitled to that type of testing. And then we agree with guidelines, and all guidelines say that inherited genetic mutations, these are your BRCA1, BRCA2 mutations, inherited by your birth parents, so in that germline line, that germline mutations and somatic mutations should be tested for in ovarian cancer patients. All right, so what is being done to address these barriers? This would be the shoring up, much needed shoring up when it comes to education and awareness on the patient side, right, and on the provider side. So that first bullet, lots and lots of coalition work with the broader cancer community, particularly with respect to education and awareness. So we've been parts of lots of these conversations. Of course, the dialogue is ongoing. We certainly have our work cut out for us as a cancer community overall. But again, important to emphasize that within the cancer community, ovarian cancer really is a trailblazer, being one of the first with BRCA1, BRCA2 mutations, and all of the different sort of diagnostics and therapies that have followed. So legislatively, what does all of this mean? So there have been efforts at the state level and at the federal level, less so at the federal level, but this, of course, is what lured you to this session, federal level being Congress, and we're going to walk through those in a second. But state level, we've seen action in California, Massachusetts, Illinois, and I think another state that may not be listed there, but around addressing prior authorization as a barrier when it comes to private insurance coverage. for particular patients. So this is kind of in the spirit of nibbling around the edges of policies that are restrictive when it comes to the type of testing that we just talked about. And then at the federal level, which is really important, right? Because that has impact beyond at just the state level. And we're going to walk through those in a second. There are two worthy of discussion. All right, so the first, and you may have seen rumblings about this bill, this was introduced in June, just this past June, and Force led the charge here. Force is facing our risk of cancer empowered. We work with them on a lot of different issues. And when it comes to policy things, there's always an advantage to teaming up across organizations. So we definitely are part of a lot of joint initiatives with Force. Anyway, HR 4110 is the Reducing Hereditary Cancer Act of 2021. So Medicare covers genetic testing for beneficiaries already diagnosed with cancer. So this is regardless of family history or a known genetic mutation in the family. So this is great, right? And it's kind of rare, right? Because you typically don't see Medicare doing anything in the name of prevention, which is part of the reason why this legislation is necessary. That second box right there, most private insurers cover genetic counseling and testing for appropriate individuals, including those without a cancer diagnosis, as well as people already diagnosed with cancer. It's critical that Medicare beneficiaries have access to the same cancer screening and preventative measures as their counterparts with private insurance.
Right, and just to be clear here, Medicare currently does not cover any sort of genetic testing for people in the family whose family members have been diagnosed with ovarian cancer. So that's what we're really talking about here. If your mother has been diagnosed with ovarian cancer and has had genetic testing to determine that they have a mutation that might enhance your risk, Medicare doesn't currently cover that kind of testing yet. That's why this bill is important.
Yes, thank you, Chad. I misspoke on that earlier. I get there. It's such a patchwork of coverage policies. Yes, that's right. That's important. Thank you for saying that, making that crystal clear. All right, so this is kind of like repeating what Chad just said. So taking it a step further. So Medicare is barred from covering potentially life-saving, risk-reducing procedures such as the oophorectomy. So this surgery is crucial for women at high risk of ovarian cancer because there is no reliable screening or early detection for ovarian cancer. And more than 75% of affected women are diagnosed in advanced stages. So this means really that early diagnosis with ovarian cancer is everything and can change the prognosis. So that's why this coverage is all the more critical. So second sub-bullet, up to 25% of ovarian cancers are attributable to an inherited genetic mutation. The median age for diagnosis of ovarian cancer in the US is 63 years old, meaning half of all persons with ovarian cancer are Medicare beneficiaries, which is why closing this coverage gap is so important. The impact would be huge.
And that 25% is only currently what we know are actionable variants. And it's when you look at the pipeline of different therapies and the sort of explosion of NGS sequencing, I think that we're likely to see that number rise as we learn more about the cancer, as we get more data that is shared across platforms to determine if there are more actionable variants. I think that you're likely to see that 25% number increase.
That's right. All right, and as a lot of policies do around sort of coverage requirements, setting baseline coverage requirements or changing the baseline, it hooks to guidelines. And this is a way of making these coverage policies evergreen, you know, in terms of the evolving science. And in this space, to Chad's point, right, that list is long and growing as far as like what mutations carry different sorts of risk and what they mean, and managing risk and sort of VUS's variants of unknown significance changing and maybe becoming known significance. So anyway, this policy would hook to guidelines to keep it evergreen. And then the second bullet there, for Medicare beneficiaries who have an inherited mutation causing a moderate to significant increased risk of cancer, the law will enable coverage of expert recommended increased cancer screening, right? So this bill is not just about ovarian cancer, it has broader reach to all genetic cancers. So for colon cancer, for breast cancer, right, that might mean breast MRIs or more frequent colonoscopies. And then the second bullet there, sub-bullet in red, applies to us. That would be the oophorectomy, so proactively or preventatively removing ovaries and or fallopian tubes. All right, so here is what the bill looks like. There you can see Representative Debbie Wasserman Schultz, a breast cancer survivor herself, is leading the charge. And then her original co-sponsors are Representatives Miller Meeks, Slotkin, and Rodney Davis. So importantly, right, this bill was introduced with bipartisan support, which means a lot in DC. All right, so OCRA, along with almost 50 other patient advocacy, primarily cancer patient advocacy organizations, have endorsed the legislation. And notably, we have a complementary piece of legislation that has been in the works for a few years now, and we hope to introduce in the next couple of months on the Senate side. And this bill would shore up the testing environment when it comes to the private insurance market. So as one of the earlier slides mentioned, right? So most cases of ovarian cancer are diagnosed at age 63, and almost half of folks at age 63, they have private insurance. So to reach them and be sure they're able to avail themselves of all of the sort of tricks and tools of precision medicine, all of these new diagnostics, you have to reach the private market too. And so that's what this bill would do. So more to come on that, really exciting. Again, something we hope to have finally come to fruition in the next couple of months. But in the meantime, want to highlight and fully throw our support behind this House bill. So again, that's HR 4110. And it is the, Reducing Hereditary Cancer Act of 2021. So now we're going to really mix it up and talk about another bill at the federal level, more word salad and numbers. And this would be HR 1946, and it does have a Senate companion, the same legislation, just on the Senate side. The bill number there is S 1837, and this is the Medicare Multi-Cancer Early Detection Screening Coverage Act of 2021. So again, when we think about the insurance coverage market, right, and policies thereon too, we divide it into two, right? You've got the private and the public. Excuse me. And within the public sphere, you have Medicare, right? And then you have Medicaid, and then private is mainly employer-sponsored coverage, but you also have marketplaces. Just important, I think, for level setting for this conversation, but this legislation, like the last piece of legislation, affects Medicare. So this is, and it's a little bit different, right? The diagnostics we talked about had to do with your germline mutations. So these would be, right, like inherited genetic mutations from your birth mom and your birth dad. Now these screening tools screen for biomarkers of cancer in its earliest stages. And so this gets at some of the tools developed by Thrive and Grail and other emergent disruptive innovators kind of in the space. And this tool is not just for ovarian cancer. The tool applies to what, Chad, I think 50 different
Yes,
cancer
it's
types.
dozens, right?
Dozens, right? So another thing to bear in mind, but basically what this legislation would require, it changes the Medicare statute to require coverage, right, when indicated. So it would be anyone who's over 60, right, is at increased risk for all cancer types. So it would provide coverage under Medicare for these tests when indicated, ordered under a provider, and when they're FDA approved. So this legislation dropped this past spring, and there has been there was initially at least, there were a couple of briefings and a pretty large chorus of different stakeholders lending their support. OCRA participated in a briefing about the legislation. We are still sort of watching the evidence and seeing kind of like how things are being received overall. But the thought of being able to have such a test when effectively deployed is a really huge, right? It could be a game changer when it comes to ovarian cancer. But of course, we are treading with caution, given that there is no low risk confirmatory testing in ovarian cancer. So it's not like other cancer types. The stakes are a little higher. But the point of the story is that the congressional bill associated with changing Medicare, right, which is it's part of the market, half of the market when it comes to looking at these policies, is really around these two different pieces of legislation. That's kind of where the dialogue is now. So Chad, I don't know if you have anything to add on those two bills in particular.
Well, like Vanessa mentioned, this is an emergent technology, and the idea that a single blood draw would be able to identify early markers of cancers, of dozens of different cancers, is exciting. But we want to make sure that it is FDA approved and that it works, especially for ovarian cancer survivors. But if it does work, we want to make sure that it's available to everyone. And so that's why this type of legislation is really important, so that Medicare patients would be able to have access to this technology. It's really exciting to see the type of work that these companies are doing. We're not quite there yet, but I think that once it does pass muster, making sure that these tests are working, it could be an exciting game changer, like Vanessa mentioned. So we're anxiously watching the progress of these bills.
That's right.
So I think, thank you, Vanessa, for running us through this. This is sort of, like we said, a snapshot of precision medicine at the congressional level, a little bit at the state level. But if you want to learn more about this, we encourage you to consider looking into the Advocate Leaders Program that OCRA has. There'll be a session on Advocate Leaders during the conference, I think on Thursday. I'm not 100% sure on that, so don't record me. But if you are interested, please consider coming to that session and becoming an advocate leader and joining us, so you can hear more about all this information and how to take action at your state level and at the federal level. But thank you very much. Hope you're enjoying the conference. Thank you for taking in our session, and we hope to hear from you at the Advocate Leader session.
That's right. Thanks, Chad, and thanks to all of you.